message it to me. Um, or you could just DM me it to me. But yeah, get you we'll get you that message as well as the PowerPoints afterwards. Didn't share the PowerPoints earlier just because this there's some answers at least in mine and Anuja's. So yeah, we'll send it to you guys afterwards. But yeah, since we're just a minute past 35, just wanted to welcome you all. Thank you guys for being here. I'm Victor, and I'm joined with Dr. Anuj Patel. We're both PGY1 residents here at the VA Southern Oregon. And so, yeah, we're just glad to have you guys. We'll be talking about yeah, well, I'll be going first, just going over some of the basics and statistics, some of the big points to really focus on for the NAPLEX. We'll probably have like a 10-minute break in between. Um, and just a little bit of break, and then we'll start the second half with Dr. Patel, and he'll be going over some of the big calculation concepts. But just to introduce you guys, introduce myself to you guys. As I mentioned, I'm from I'm a PGY1 here at the VA Southern Oregon, and I did my school actually at the UC San Diego, so just a little bit far from here. And I will give it to Anuj.
Hey guys, so again, thank you guys for being here. We appreciate you guys taking the time out. Clearly, you guys are showing dedication to doing well in the Naplex, and hopefully, when we're done with these next 2 hours, you guys have taken away something substantial to help you guys through the Naplex. My name is Anish Patel. Again, like Victor said, I am a PGY1 here at White City, VA Source. I did my pharmacy school out in Atlanta, Georgia, at a school called PCOM, PCOM School of Pharmacy. And I will be staying on board here to be a clinical pharmacist. And Victor actually was accepted to a PGY2 program up in the VA Portland. So that's kind of our future plans as well too. So that being said, like Victor said, we will be spending the first hour with Victor doing biostats, and we're dedicating all that time towards that. Any questions that you may have, we can definitely ask in the middle, work out problems in the chat, or raise your hand. We want to answer them as we're getting to them. And at the end, we'll have a 10-minute break. And again, you guys can stick around, ask more questions, and we'll be glad to answer them. And then we'll switch over to calculations after for another hour as well. Again, please ask questions as we go through it. We will have actual questions asked to you guys as well within the PowerPoint itself. So active participation will be great. Any questions, please speak up. We're not your professors. We want to keep this a very casual environment so you guys can get the most out of it. Because at the end of the day, the goal is to kind of answer any questions y'all might have to leading up to the NAPLEX so you guys can understand these concepts and do well. Because I'm sure you guys have heard, calculations and biostats is a big chunk of the NAPLEX. And that's one that you're guaranteed that it will be in there. Unlike the other disease states, you have a bunch, cardio, onco, ID, gastro. You don't know which ones you're going to be tested on. The NAPLEX isn't going to test you on every single one. You'll have a chunk of one or the other and none of anything else. My example, for example, I studied a lot of cardio, onco, ID, and then I got smacked with a bunch of gastro and a bunch of women's health and male reproductive health. And I was almost blindsided because I spent maybe 1 or 2 days on it, and when I spent weeks on cardio, onco, ID, etc. So the one consistency you have here is you will all get a large portion of calculations in biostats. So excelling here and acing this material will go a very long way in helping you get a passing score for the NAPLEX. So that being said, I'll turn this over to Dr. Tang and he will get started. Thanks, guys.
All right, yeah, thank you, Anuj. Yeah, so I'll just kind of get started here. Really, we're going to cover some of the basics and statistics as well as some of the areas that I think we see it so often. We do journal clubs, and it's something that, we just kind of recognize secondhand, but really just going into the nitty gritty of it, being able to identify them, in the academic terms, that is actually something that the NAPLEX does ask you about. So I think really just developing the familiarity, dealing with some of the calculations and interpreting some of the statistical results, especially when it comes to risk, is something we'll be covering a lot of. And as Dr. Patel has mentioned, one of the really big things is that statistics and calculations does encompass a pretty big portion of the NAPLEX exam. At least for statistics, you're probably going to see about 5% of the questions. So, the NAPLEX 250, 5%, you can kind of do the math. There are going to be quite a few questions with that. And if you can really ace them, that's just kind of guaranteed points right there. And just kind of going over the objectives, what I sort of alluded to before, really the hypothesis testing, being able to recognize the data types. Believe me, they do actually ask you about that, as well as the big calculations, relative risk, odds ratio, number needed to treat, number needed to harm. Being able to calculate that and interpret that is going to be something that's going to be pretty big in the NAPLEX. I'm pretty sure I had at least 5 or 6 questions with the actual calculations and interpretations of these. So just to get started, I'm just going to go over some of the basics here, and we're just going to be looking at the types of the study data. So this is kind of more of the basic element of statistics. When we look at these certain studies, we really look at quantitative data. So that's kind of the value of the data in forms of counts, forms of numbers, where there is a unique numerical association with it. Really answering, the questions of, how much, how often, how many. And when we look at quantitative data, that can be broken up into two groups of it. We have the discrete side and we have the continuous side. Discrete, oftentimes we'll recognize it as a categorical. So these are, as it kind of implies, these are going to be more binary choices. When we look at nominal, we'll be digging into this a little bit more, but looking at nominal and ordinal data. And then when we look at the continuous side, that's kind of what we're more familiar with. Those are kind of more of the numbers. Something like on a number line or so forth. So that's kind of what we're more used to seeing. But being able to, identify and discern between the two groups, and even in the subgroups in between, these are questions that will be asked in during the actual exam. So when we look at discrete data, as I mentioned, this is categorical data. There's going to be two. Binary is kind of a special one, and that can kind of fall into either of these categories, depending on how it's phrased or how it's used. But nominal data, what we often see with that is it's sorted by categories. These are going to be the yes/no questions. There's no particular order associated with it. So, kind of looking at some of the examples, male or female, smoker or non-smoker, blood type, or eye color. These are things where you're one or the other. And when we assign perhaps like a value to it, like if you're male, you get a 0. If you're female, you would be assigned 1. Vice versa. Does it really matter? Is there an order associated with it? There really isn't. So that's why that is considered categorized into the nominal side. When we look at the ordinal side, that's what is said in the name. There's an order associated with it. So when we take a look at that, things like pain severity scores, what you scored on the PHQ-9 questionnaire, the New York Heart Association classifications for heart failure, these are, number scales. And as you could see from it, there's a clear order to it. Obviously, for like a PHQ-9, the higher the number it is, that's associated with more severity. Lower is a less severe. So, there is a specific value associated with it, and it corresponds to something in which, you would logically order it in that sense. So that's going to be that. When we look at continuous data, um, the big difference between ratio and interval data is whether or not there is a true zero associated with that data set. So when we look at ratio data, these are kind of the numbers that, with a clinical trial is what we most often see. So demographic data, age, weight, height, serum blood levels, or such. These are values where, if the value is zero, it makes sense. It makes sense in that in within that range. So obviously, age zero, or zero age, they weight is zero, they weigh nothing. So really, zero really means what it says. Interval data is a little bit different. Even though it can incorporate a zero, it's not what is called like a true zero, just like how we have on the other side of the equation. So there's fewer examples associated with it. Temperature scales is going to be one of them. We have 0 Fahrenheit. It's not necessarily a true zero. I mean, you can extend farther down that range, and the values can mean and the values mean something else. But there is a clear distinction between them. So 1 degree Fahrenheit, it's on a number line. It makes sense. We could see the difference with each integer. But when we look at the value zero for it, is it really corresponding with null? So temperature is going to be kind of one of the classical examples with it, except for in the case of Kelvin, because as we know, 0 Kelvin actually, that is the absence of pretty much all energy. So that is actually a true zero. Fahrenheit, Celsius, those are not. Also, when we look at clock time, um, those and SAT scores, those zeros are more arbitrary. So it's kind of hard to kind of it's a little bit hard sometimes to kind of differentiate the two. But when you guys try to sort it out, we really just ask yourself, if the value is zero, does it make sense on the number line for that particular value? That's a big for me. So here's just a question for you guys just to work through, and you guys can just put the answer in the chat if you will like. Just some questions I had wanted to see where we're at with it. So really defining what type of data is listed below. So this will be your nominal, ordinal, ratio, or interval. What would you guys say like a home blood pressure reading would be? you know, Millimeters of mercury. Would that be nominal, ordinal, interval, or ratio? If nobody types in, someone wants to type in the chat, or you can speak up too if you guys prefer. Well, if nobody's answering, I guess, in the case of blood pressure readings, this could be a numerical value. That thing we know for sure for just it being quantitative data. But when we see a 0 millimeters of mercury, is that a true zero? Well, that would be the absence of pressure. And so, yes, this does have a true zero. So in this case, it would be a ratio data set. What about with the case of like a 30-day readmission for heart failure? When that's often sorted as a percentage wise. Does anybody have an idea what that would fall under? Ratio or interval? In this case, it would be on the ratio side once again. So in this case, what we're having is going to be, when we look at it again, 0%. Is it a true zero? Yes. It makes sense. That means, there was no 30-day readmissions. So in that case, the zero there is a true zero associated with it. Chad's Vask, I guess that is going to be. If it was, that's a good question. If it was a yes or no, in that case, that would fall into more of the categorical side, more of the discrete side of things. So if it was just whether yes or no's, it would be on the nominal side because there isn't really an order associated. Whether or not you put no before yes or yes before no, it doesn't make a difference. Uh, so there's going to be that. And probably a good exercise just to think about is like, what about a Chad's VAS score? What exactly would that fall under? And in this case, you look at it in the whole picture as well as looking at the individual components, and you'll get some interest in you. And when you now analyze it, you'll get a little bit of there's the interpretation of it. It can kind of go either way, but for like a Chad's VAS score, when we look at the sum score, once again, ask yourself: is there a true zero associated with it? Well, a Chad's VAS score of zero, they're absent. That's the absence of risk factors in a particular patient. So in that case, there's a true zero associated with that. But when you look at the individual components of it, what exactly are we looking at? We have male, whether or not they're male or female, that's kind of a yes or no, or, a 0 and 1 in that case. So that would kind of fit more on the nominal binary side of things. But you also have something such as the age. That could be a 0, 1, or 2, depending on it. There's an order associated with assigning that value. And so that would be more on the ordinal side of things. So, something like a complex as a Chad's VAS score it has multiple components to it. And so it's a good thought exercise too. You could also argue about some of the other values as well, whether or not it's true binary or not. But yeah, it's going to be just a little thought exercise to go with. And I'm sure you guys are all very familiar with this when we look at central tendencies, how this is going to be, the three M's: the mean, median, the mode. Ideally, in a perfect distribution, it will be directly smack dab center. We have that nice bell-shaped curve. All three central tendency measures will be focused in the center. It is really when you have skewed data that's not normally distributed, and that's a question that's asked in the NAPLEX as well. Defining how the data looks and where the skewness is. So in this case, just a little chart I put down there. We have a positive skew, also known as a right skew, and then on the farther right side we have a negative skew, or left skew. Really, you're looking at just where the tail is on the graph. And the big thing to look for that is knowing how that affects where the numbers are located. So, is the mean going to be greater than the median, or is that going to be greater than the mode? Things kind of like that is something that is a pretty much fair game on the exam. So recognizing skewness, how to identify it, basically whether or not it's a positive or negative skew. That's the big thing to know in that. And really being able to kind of picture in your mind where these central tendency numbers line up. That's all kind of fair game from there. And yeah, and what I also posted here on this graph was more so just to kind of like, describe what the central tendency measures are, and kind of what data is often used in those scenarios. So when we look at a mode, that's going to be our continuous, those are going to be, interval ratio data, nominal, ordinal, those would be included in it. And then when you look at the other side of, such as the mean, really, you can only calculate a mean with numerical data. I mean, continuous data to begin with. So just kind of like just a good page here for reference. So I'm going to move into hypothesis testing. This is going to be probably just getting more familiar with the diction, with the way that the way it is presented on the exam. Um, just this is kind of more just a refresher because I'm sure you guys have seen it. But when we do testing, especially in a clinical trial of sorts, there is a null and there's an alternate hypothesis associated with it. So more often than not, the most common thing you'll see with a null hypothesis is that it stands for there's no statistical significant difference between the groups in the study. And so that's going to be defined as H0 or H null. And with that, what's the goal in the clinical trial? Um, you know, the H null, the null hypothesis, is the status quo. It is what we're ultimately trying to disprove, what we're ultimately trying to reject, in favor of the alternate hypothesis, which I'll just get into a little bit. But really, the study is, we're trying to show significance. We're trying to reject the status quo, and in that case, provide enough evidence from our sample study to make an inference out into the population. So making it so that uh, giving the evidence that the alternate hypothesis, so like in this case, maybe our new experimental drug is better, that's what we wanted to test. So, H null would be that it's similar to placebo or similar to the current standard of care. While our alternative hypothesis is that it's better. What measure in which we use to define it being better or not is going to be different, obviously, in a lot of cases. But really we're trying to find the significant evidence to prove that null is not the correct one. The alternate hypothesis is what we're aiming for. And I already kind of went over this just briefly, but yeah, the notation for an alternate hypothesis is going to be a capital H with a subscript A in there, and that is oftentimes this hypothesis is going to be that there is a statistical significance between the treatment groups, and it is something that we want to accept at the end. So either you reject the null and you accept the alternative, or if there's not enough statistical significance, unfortunately, we would have to reject the alternate and accept the null, in which case there was no statistical significance. So just to kind of give you guys a little bit of an idea of the notation and what we see there, I know oftentimes when we look at a clinical trial and it's going to be what's presented during the NAPLEX. They'll just give you a clinical trial, and they'll say, well, the objectives of the study is to look at the efficacy of so-and-so drug. Really just picture in your mind, what's the null, what's the alternative, and when you write it down, it really needs to, they'll be really seeing whether or not the notation makes sense. So here's a sample question that I put in just to kind of help you guys with identifying how to write a null hypothesis. So in this case, there is a trial. We're comparing drug X and drug Y for treatment of diabetes. X is pretty much the standard of care thus far, and Y is the new drug that is just recently approved. As pharmaceutical companies would want. They believe that it's a more efficacious drug in this case. So in a study such as this, where we're trying to prove that drug Y is better than drug X in terms of efficacy, what would be the null hypothesis that we're aiming for? So yeah, if people have guesses, type in the chat there. A is, the null is drug X greater than drug Y. They're equal to each other in B, vice versa in C. And this is where you kind of get into notation. That's going to be the mean and the margin associated with the margin. Uh, so yeah, without any response, the answer would be B in this case, because really the goal in this case is that there is no difference, and that's what we're ultimately trying to overcome and disprove in order to show significance with our drug. Alpha, you'll see that notation. Yes. So with a non-inferiority test, they would be flipped it because I think when you look at it, that's kind of actually what I used it as answer D. So that would be the case where you're looking to see if the mu is similar and whether or not it's associated with the margin of with a certain margin of error. So in this case, yes, it would be flipped in this case. Hopefully that answered your questions. I can provide a better explanation to chat later on, but yes, Caitlin's correct. It would be flipped in that case. Alpha, really the big thing to know from this is, this is where we assign our level for significance, and we'll actually talk about it a little bit more when it comes to type 1 errors later down in this presentation. But yeah, alpha is going to be the number that we commonly associate with what is the threshold for rejecting a null hypothesis. Most oftentimes we see a p-value of 5. We set the significance level as like, hey, if it's less than 5%, it's or 0.05, then it's significant. That's kind of what this value represents. And it's really what alpha truly means is what's the probability of concluding that there is a difference, between the groups. Um, and how it ties into a type 1 error is that it actually, well, we'll actually get into that just a little bit. But factors that we take in control when we assigned an alpha, like I said, most often it's 5%, but sometimes you'll see a study that's 10%. If the study is really well designed, it will be a 1%, but it would also mean that it's more resource intensive, and that's kind of what's associated with what I listed as the factors that affect alpha. If we see a large magnitude of an effect, our alpha can be a little bit stricter because we have the effect to kind of make up for it. We don't necessarily need as big as a sample size to prove that there is a difference if the effect is already huge. That's kind of the way I generally look at it. And determining statistical significance, like I said, this is when we look at alpha, we're looking at what's the threshold in which we're willing to pass to accept something as statistically significant. So here I just kind of just drew a diagram just for everybody's reference. When we look at a difference, such as like between the two drugs, seeing if it's significant or not, the p-value there is to basically help us, base the judgment of whether the data is significant. Obviously, if the p-value is lower than the threshold, we'll mark it. We'll accept the alternative. We'll reject the null, as we can see on the top side. But if it's not necessarily the case on the bottom, then we're going to reject it. This also ties into the confidence intervals, which we see in a lot of our studies. And in the NAPLEX, they can give you a p-value, they can give you a confidence interval. You should be able to use them pretty much interchangeably at this point. So, the calculation for a confidence interval, it would be, 1 minus the alpha. So, in a traditional study, if we set an alpha at 5%, what's our confidence interval going to be? It's going to be a 95% confidence interval, 1 minus 0.05. And that's the one that you most commonly see. They can provide you with a difference confidence interval. It's not uncommon to see a 90% or an 80% confidence interval. Obviously, in those cases, the precision isn't really there. But just being able to interpret it is going to be the big part of the NAPLEX. So really, the interpretation, we're in this case, let's say it's alpha is equal to 5%. In the interpretation, we would be that, hey, we are 95% confident that the true mean, the true value lies between, our lower bound and our upper bound of this confidence interval. And the one thing that we should always take a look at is really if the confidence interval includes the value 0. If it's a 0, that means it's not significant. That's just going to be the quick and dirty of it. So when the NAPLEX doesn't give you a p-value and it gives you a confidence interval instead, if you know the alpha, which you will, because there's the equation right there, it's going to be 1 minus the alpha. If you see a confidence interval with 0 accompanying it, you know it's not going to be significant. So yeah, I'll run through this question real quick. So, what about in this case? There's a study looking at a new triglyceride lowering agent. In the study, when they compared it to placebo, the mean reduction in the triglycerides was between 150 um, and when we look at so the mean was negative 150, we showed a reduction there, but the confidence interval accompanied negative 378 and 5. Just from the fact that it's a 95% confidence interval, are these results significant? Um, and I don't see any. Yes, Lindsay is correct. It accompanies a 0. So in that case, we saw that there were in the upper range of things there was people that potentially had an increase in lipids or triglycerides with this medication. So when we look into the precision of this, the fact that it accompanied 0 means that it would not be significant in this case. That's pretty much the big takeaway from using a p-value and a confidence interval interchangeably. And one thing that we should always take a look at is really significance. This is a term that we will see throughout our careers. There's a difference between the statistical significance and the clinical significance. And I know a lot of you guys are in journal clubs. Maybe you guys will do journal clubs in the future. But the big question is always like, well, even if it's statistically significant, does it clinically make sense? Is it clinically worth doing? And that's just a question just to think about in the future, seeing whether or not there is a true difference. Does it make a meaningful impact? And when we talk about pharmacoeconomics, is it worth justifying the cost in that case? So just kind of some food for thought in that sense. Errors. This is the part where I'm going to be where I mentioned before, in which we're going to be talking about alpha. So there's two types of errors that you can make in statistical testing. There's going to be our type 1 and our type 2. So in a general sense, the easiest way to remember it, type 1s are false positives, type 2s are false negatives. I put the interpretations over there. And so when we look at it, so in a type 1, we accidentally accepted the alternative and we rejected the null when it really wasn't the case. So really in the end, the null hypothesis was correct. The status quo was actually correct. On the type 2 side, that's when it's a false negative. So in that case, the alternative was rejected, but in truth, there was actually a difference. And so the alternative shouldn't have been rejected in the first place. It should have actually been accepted. And so what are the values associated with it? So for type 1s, that's fairly simple. That's going to be alpha. We set this threshold that, hey, the p-value needs to go to this, it has to go below this to show that it's statistically significant. Well, that's the area where, there was a chance that, hey, perhaps maybe we accepted it when it's maybe not necessarily the case. So type 1's alpha, that's the easiest way to remember it. Type 2's, on the other hand, that is going to be result that's going to be related to beta, and I'll actually just go over that real quick. And so beta is really it's associated with power, and it's going to give us our probability of committing the type 2 error. And so this one, it's going to be a different number. You know, we're not going to see like a 5%, kind of like what we saw with alpha. Generally, it's going to be zero point 0.1 or zero point 0.2. When you look at clinical trials, what we often see is a power of 90%, 80%. Well, you can kind of, from the equation that you see below, the power is calculated by 1 minus beta. So that can kind of give you an idea of what the beta value will be if the study presents what power is located, what the power is. And so power is really, that's exactly kind of what it sounds like. It's what's the ability to reject the null, what's the ability to reject the status quo, what it really is a difference. And a lot of the things that can contribute to that sample size, once again, the effect size, this is kind of what we saw with the alpha as well. And just looking at also the variability of the outcomes. So I would say the big takeaway is type 1s, those are going to be on our false positive sides. Remember that it's going to be with alpha. If type 2s are our false negatives, it's going to be with our beta. Um, and that's going to be the big thing that they'll ask in the NAPLEX, being able to discern the errors and what is the value associated with it. In this example, I just provided, here's an example, there's a study looking at the rate of nausea and vomiting cases between, two different drugs. Due to the low sample size, you had to set the alpha at 0.1, and you had to set the beta at 0.3. Just because I feel like I hopefully hammered it into your guys' head well enough. Type 1 is going to be alpha, type 2 is going to be beta. Type 1, what's the probability? It's going to be 0.1, 10%. What about type 2? It's going to be beta. It's going to be 0.3 or 30% chance. And yeah, and here I just kind of put it into the calculations for it. I mean, well, there wasn't really much of a calculation associated with it. So I'll just skip over that. The next part is probably what you'll probably see the most of, and that's going to be risk. So this is going to be relative risk and odds ratio. And relative risk and odd ratios, they're fairly similar. I'll tell you guys pretty much what's the big difference that you'll look for when you decide which one you'll be using. But relative risk is probably the one we're most comfortable with. It's the chance of, an outcome happening, when there's an intervention given. This is what often we see calculated in our prospective cohort trials when we look at, a drug versus a competitive or versus a placebo in a controlled environment. This is the one that we see most of the times. If we have a relative risk ratio of 1, if our relative risk is actually 1, it will be showing that there is no difference. It's when you start getting values that are either less or greater than 1 is when we have whether or not there's a higher risk associated with the treatment group, whether or not there's a lower risk. Those are the values that we would discern from that. So just remember, relative risk, if it's 1, chances are it might not be significant, or if it's really close to that. This did not show up the way I wanted it to, but I'll actually just move over to the next window. So this is kind of just giving you an idea of how you would calculate it in this case. So when we divide it up into the calculation, as I mentioned, it's the risk in the treatment group and there's a risk in the control group. So in this case, when we look at the risk in the treatment group, which are the two popular, which of the quadrants are we really focused on? It's kind of simple in this case. We're looking at the top row and the bottom row. So in the treatment group, we had In the first quadrant, patients received the treatment, the outcome was present. A is going to be the one we're interested about. For the denominator, what's the total amount of patients that did receive the treatment? Well, that's going to be A plus B. The B being they were treated with it and the outcome was absent. Similar case with how we calculate the control, and that's going to be on the what's the risk associated with the control group. And then it just becomes one big fraction at the end. So just posted it right there just for reference. But just remember, the big thing you're looking for, if you have to remember it, is what's the risk in the control? What's the risk in the control? What's the risk in the treatment? And you put it into a fraction, with the treatment being on top, obviously, because we're looking at what the changes with the experimental. So in the interpretation here is generally, we're going to get like a numerical value. So like, let's say in this case, the relative risk was 1.7. So the treatment group were more likely to have a specific outcome. It's like, well, the interpretation in that case would be the patients in the treatment group were, 1.7 times as likely to have received the outcome. Same in the case with if it was like a less than one, if it was like 0.3 or something, they were 0.3 times as likely to get the outcome. I don't know why these are not showing up, but I guess I will give it here with this example. If you guys have the opportunity to calculate it, really just looking at, in this case, we're looking at what I went through before. If you take a look at it, you're still kind of seeing that A and B, C, D column. The top row would obviously be the cases of those exposed to it, and the bottom would be those that are on the placebo. So you would put the two risk groups. Obviously, what's the risk of the treatment group on top? What's the risk of the bottom group? And then that will give you your relative risk. Here in this other example that I wanted to give was more so just interpreting it. So in this case, patients on NSAIDs, associated with a higher risk of GI bleed. So when we compared it to those who don't take NSAIDs, the risk ratio turned out to be an 8.2. Well, what does that necessarily mean? So just for the sake of time, the answer would be C. The NSAID users are, like I said, the risk ratio was 8.2, so there were 8.2 times greater risk associated with developing a GI bleed compared to those that. Actually, no, the answer is D, actually, because we always want to put it into the context. So 8.2 is likely to develop a GI bleed compared to those who were not using NSAIDs. So yeah, so D in this case would be the right answer. This is relative risk reduction. This is going to be actually a fairly important equation along with the next one. And this is more of looking at how much of the risk was reduced between the treatment groups and the placebo. And so when we there's two ways to really calculate it. Percent risk of the control minus percent risk in the treatment, and you divide that by the control. So that'll give you the value, or you could just do 1 minus the relative risk. And oftentimes with this, like let's say in this case, the relative risk was maybe 3% in the treatment group, and it was 5%. No, let's say 6% in the placebo group. Well, what was the relative risk reduction? Well, it was 3%, which is actually about double what was in the treatment group. So you would say the relative risk reduction in this case would be pretty much like an additional fold. So that would be like a 100% difference. So in that case, this is what we oftentimes have reported in the clinical trials. So this is just one of the values where you'll see it a lot, but really take a look at it and see, was the magnitude difference really there? It's almost always going to be a bigger number compared to absolute risk reduction, which I posted here. So in this case, once again, treatment group 3%, and the placebo group was 6%. Well, in this case, it would just be 3%. What really sounds better, 100% or 3%? That's going to, that's not something that's reported as often. And so in this case, just recognizing that is going to be pretty key into interpreting it during the NAPLEX when they ask you, the absolute risk reduction of this was how would you interpret it in the study? Well, this is the absolute difference compared to the relative, where the difference is relative to the control side. So in this case, what we have here, what absolute risk reduction really plays into is the number needed to treat and number needed to harm. And this is a value that we see reported a lot in the clinical trials, and it's important to be able to interpret it. So number needed to treat, the calculation for it is 1 over the absolute risk reduction. There's a little typo there. Number needed to harm, not number needed to treat on the right-hand side. It's actually the exact same thing, except for it's an absolute value this time around because, the value can be negative, and we don't want the negative to carry over to the actual numerical value. It wouldn't really make sense in that case. So really the definition of number needed to treat is, how many additional patients will we have to treat with this new treatment compared to the status quo or placebo for us to really obtain one benefit, for one patient to receive a benefit with that. Number needed to treat is interpreted in the exact opposite. How many patients will we have to treat for one patient to experience a harmful event associated with it? And kind of looking at kind of like a seesaw. In this case, what we're really looking for when we look at the values is we want our number needed to treat to be as low as possible. So that means, we have to treat less patients to receive the benefit. And we want the number needed to harm to be the highest it can possibly be. So we have to treat like 100 or 1,000 patients for us to receive a harm. Obviously, treating 1,000 and receiving one event versus treating 100, once we reach 1,000, there'll be 10 events. You want that number to be as high as possible in that case. So yeah, just knowing the interpretation of it, it's the number of patients to, depending on if it's treat or harm, for one patient, how many number of patients we need to treat for one patient to receive the benefit, or for one person to receive harm from it. That's the biggest thing, is interpreting that and being able to calculate it. I think there was at least 2 questions on NAPLEX on how you would calculate it, and followed up by how you interpret it. So an example in this case, everybody's favorite cilostazol and aspirin secondary prevention for TIA compared to clopidogrel with aspirin. So cilostazol is going to be our treatment. Standard of care will be our clopidogrel with aspirin. And when we look at the risk, what's the risk of experiencing a recurrent TIA within the 12 months of therapy? It was 1.3% in our experimental group, 3.5 in our control group. How would you calculate the number needed to treat? Well, first of all, we would start with the absolute risk reduction. And how we would do that is control minus the experimental. So, 3.5 was what was associated with the clopidogrel, 1.3 was associated with the cilostazol. So we take the difference of that. That'll give you a 2.2% or 0.022. And how do we calculate the number needed to treat? It's that equation. It's 1 over the absolute risk reduction. So when you put that in there, you're going to get 45.45. In this case, you do want to round up when you can. The thing with number needed to treat is you want to round up because you don't want to accidentally overstate the benefit. So this would be a difference between 45, like, oh, well, we need to treat 45 patients to receive one benefit, or we need to treat 46 patients to receive the benefit. Obviously, if you report to 45, you could potentially run the risk of overstating the benefit. So that's why you give yourself kind of, let's say, the worst off number, which, I mean, it's not necessarily, it's not worst off per se, but that's what, in general practice, what you would do. So yeah, and so in this case, the interpretation, every 46 patients treated with Salostazol or ASA for 12 months, a recurrent TI would be prevented for one patient. So every 46, one patient benefits. But what about the number needed to harm? So like in this case, there was actually an increased rate of intracranial bleeds associated with salostazol compared to clopidogrel. Once again, not necessarily applicable to real life practice. I just chose just this drug randomly. But how would you treat the number needed to harm in this case? Uh, in that sense, once again, it's sorry for a typo there. Should be number needed to harm equals 1 over absolute risk reduction. It's the exact same calculation, except for on the denominator we do find the absolute value of it. And so when you plug it in, ultimately plug and chug, we get 111. So what does that necessarily mean? So in the interpretation, when we look at number needed to harm, it would mean that for every 111 patients treated with the salostazol, um, sorry for a typo there, with the salostazol for 12 months, we would see one patient develop an intracranial bleed. As we saw, there was an increased rate of intracranial bleeds with the salostazol. Not a whole lot, that's a 0.9 difference. But it is higher. So the more patients we treat with it, we're going to see an additional case compared to if they were just treated with the standard of care, clopidogrel in this case. And I'll send out a correction of these slides later on as well, just so the typos don't stand. Odds ratio, it's interpreted the same. It's very similar. I think the big takeaway in this case would just be when do we use the odds ratio compared to a relative risk. When we look at an odds ratio, the big thing is going to be whether or not it's a case control trial. So in a relative risk, we know the number of patients at risk. We knew how many people we put in the treatment group, how many we put in the control group. We know who's at risk and who's not. When we use the odds ratio, we're kind of looking farther back. So this is more of like one of those retrospective, chart reviews that you do. So we would assign we would assign our cases, we'll assign our controls, how many of patients were actually at risk at that time. It's hard to say. We're doing it retroactively. We're looking back. We're just clicking. These are our cases. These are our controls. 500 in each. In that case, it's a little bit harder to tell because, like, was there more that were exposed? Was there less? So really, the rule of thumb here is if it's a case control trial, um, it will always be an odds ratio. You will never be able to calculate relative risk from a case control trial. So that's really the big thing I wanted to point out from that. When we do the calculation for it, it's a little bit different. How I usually remember it is that, we're looking at the results that make sense versus the results that can't really be explained. So odds ratio, odds that a new case was exposed, and on the denominator, odds that a control was exposed. So when you look at it, the numerator would be A and D. Does that make sense? So the A group is those that were exposed and they had the outcome. The D is the group is those that didn't have the exposure, and the outcome was absent. Those results make sense. I put them in the numerator. I put the remaining groups in the denominator. That's the best way I would remember how to do that when the actual exam comes. And the interpretation for it is actually fairly similar to relative risk as well. In that case, you're saying more of the exposure or And well, these slides are not that good. But yeah, the way you interpret it, and usually if you're doing a prospective cohort study, and if you calculate a relative risk and odds ratio, chances are they'll probably be the same. Just know that an odds ratio is specific for case controls. Here's another example, just calculations for you guys. How would you calculate this? Um, I'll leave this up to you. I will admit I did kind of switch this up just a little bit. So um, the A, B, C, and D's don't really line up. But that's something I will let you guys calculate later on, just for the sake of time. Here's the calculations for it. So I actually set it up. You would really get a 1.52 at the end if you went through the math to calculate it. And the interpretation in this case would be, it's a 1.52. There was a higher risk associated with those that were exposed to, in this case, high dose radiation. So they have a 52% increased risk of developing, secondary malignancy compared to those who were not exposed to it. If you guys have any questions, let me know in the chat. As we're kind of coming close to the end of it, just put this slide here just to kind of give you guys the comparison between relative risk and odds ratio. And really, in the asterisks, never calculate relative risk for case control. It will not make sense. Hazard ratio is very similar. I think when we look at relative risk odds ratio and hazard ratio, they can all kind of be interpreted in a very similar way. But just recognize that in a hazard ratio, what we're really looking for is like this the unfavorable event. And this is going to be, how many, what's the risk over a certain duration of time. The calculation for it is actually the exact same as a relative risk. So kind of like that A over A plus B and over the numerator, which it's actually the exact same way you calculate it. You put what was the treatment group on top and the control group on the bottom. I'm not going to talk about it necessarily too much, just because I'm sure we've all done journal clubs. It's the most common thing that we see in a survival analysis. Um, and here in this example, like I said, you calculate this very similar to a relative risk, and just for the sake of brevity, um, here's how it would look like. Like I said, it's calculated the exact same way as you would for a relative risk. And I just chose this example, and the interpretation doesn't necessarily make sense clinically, but you might encounter something like this, and it's always kind of good to just take a look, see what was actually looked at in the study. Does the number make sense? So in this case, I just put an example. I put some random numbers in. This is not how it usually pans out in real life with regards to ASCVD and statins. Just learning regression, you're not going to be obviously asked to perform one during the exam. It's really just identifying them, and they fall into three groups. Really, in the broad sense, you're just trying to look for a relationship between, your independence and your dependent variables. And the most common way is the most common one that we see, perhaps maybe not in clinical trials, is a linear one. That's going to be our continuous data, and it's really just going to be kind of your scatter plot graph with a line of best fit associated with it. So that's fairly simple. We know y equals mx plus b. What in that study is that they're plugging in one continuous variable. We're trying to get another one out and trying to gauge how well it predicts. What's the prediction rate? This is where we look at R. What is the correlation associated with it, as well as R squared. Is the model encompassing the variations? So, logistical is one that's always a little bit harder to picture. I always imagine it as a S curve when you actually see a graphical interpretation of it. In this case, we're looking at more categorical and seeing whether or not a certain value, such as a numerical value, is associated with it. So, in the case of like mice and obesity. One thing we would plug it in the categorical on the y-axis, maybe like, oh well, this mice is obese, this mice is not obese, and then we plug in certain weights. And if the model is true and it's correct, once you plug in a certain weight, it gives us a certain predictive factor of whether it's obese. Um, but this is kind of getting off the deep end of it. Really, just recognizing it is the most important part in the NAPLEX. The Cox model is going to be what we see with the hazard ratios, and this is going to be looking at categorical variables and seeing whether or not there's a correlation with higher risk of an adverse event or not. That's kind of the simple gist of it. And the very last two slides, sensitivity and specificity, these are going to be this is going to be brought up in the exam. Probably not too often. I think maybe I had two questions regarding it. But really, sensitivity is going to be our true positive. Specificities are true negative. And how do we calculate that? Um, it would help if I actually put the table on there. But yeah, so how sensitive it is. We're looking at whether or not we can identify uh, for all patients that have a specific condition, how many of those actually tested positive. Hopefully, it's a fairly high number, as well as the specificity of those who don't have the condition, how many of them will test negative. And so the calculation's kind of right there for you guys, for your guys' reference. Um, and I'll leave this calculation to you guys as well. But here is how it would pan out once you do it. That pretty much concludes my side of the presentation. Let me know if you guys have any questions, so if I could try to explain it a little bit better for you guys. Otherwise, I think we're going to have a 10-minute break. So um, right now it's 6:37. We'll try to come back around 6:47, and we'll have Dr. Peltel take over with the calculation side of things. But yeah, send me a chat if you have any questions. Otherwise, we'll see you guys back.
Hey guys, if everyone's back, can y'all just enter yes in the comments so I can keep track? Just make sure everyone's here before I get started. Got one, two. There we go. There we go. 9 out of 13. So we'll go ahead and get started. It's being recorded anyway, so we will be able to have it available for y'all to go back. So kind of like how Victor implied, biostats is definitely a big part that's guaranteed to show up for you guys. But another major part of this is going to be calculations. And this is not 5%. This is anywhere from 20 to 30%, depends on who you ask. So this section right here was developed essentially by taking your RX prep book, something that both Victor and I have used, and we went through it and we isolated concepts that either A, appeared frequently on the NAPLEX, or B, appeared frequently and they're pretty difficult concepts to handle. So what we're going to do is we're going to go through each one. The more difficult concepts that actually have problems in here as well too. I'd really appreciate if you guys maybe try it out. I will give you guys time to try it out as well. We will have gone over the concept right before we get to any problems. So the concepts should be pretty fresh and I can always go back. So please ask questions. Please talk it out with me. Please work it out and give me answers, because with biostats, it's very easy to kind of walk through it, explain it, and you can understand it. Calculations requires you to actually try it. You can visually know a concept, but when it comes time to applying it, a question can be asked backwards or forwards to get an answer. You just don't know what they'll ask as you to manipulate the actual equation itself. So this is going to require you guys to actually try it. So I really appreciate if you guys actually try it, post some answers. I'm going to ask some folks what they got, and we can go from there, okay? So that being started, let me go ahead and share my PowerPoint. There we go. Right here. Come on. That's not what I wanted. Wait a second, I just want to make sure I can see any questions that might pop up. There we go. That's what I want. Awesome. So let's get started, y'all. Are y'all able to see my PowerPoint? Perfect. Awesome. Let's get started. Thank you, guys. So again, I want to break it down and provide y'all a key. Anything with a QG to start off with the concept, it means it's just a critical concept or equation. I expect you guys have probably hammered down this through farm school, so we're going to kind of highlight through it. If you guys have a question, please enter it into the chat, and I'll stop and go over a little bit more if need be. I have an hour with y'all, and calculation is pretty in-depth, so I'm trying to hit this as quick as I can, but be as thorough as possible as well, too, for you guys. Anything with ID, in-depth concepts are going to be another critical concept or equation, but it's going to be a little bit more tougher to grasp. So because of that, I'm actually going to sit down and actually go through the actual problem itself, how to work it out, and then provide you guys the practice problems to try as well. The range in difficulty on how the NAPLEX might ask you guys the questions, I'll point out how it can be flipped around, but the concepts and questions are going to be pretty relatively simple for you guys because of our limited time. So I've broken down different concepts in terms of calculations. These are going to be the more core calculation concepts for us to start off with. So one of the basics that you guys need to know, because you will be required to manipulate conversions throughout the entire NAPLEX, not just with calculations, but even concepts that are outside of calculations as well too, in terms of disease states as well. And when you need to know target doses, max doses, they might throw you a curveball and say instead of 4 grams, they'll say 4,000 grams, or they might milligrams, or they might say 0.04 to really throw you around. So you got to keep in mind of those conversions. Be very careful because the NAPLEX will throw you curveballs that way. So this table is going to be key, and the next table. You want to know these volume conversions. To make life real simple for you guys, I feel like instead of knowing each one part by part, you would be pretty safe to say knowing the average will be well enough for y'all. You don't need to know the exact numbers. Knowing the average will get you close enough to an answer where if you're rounding, you can pick an appropriate answer. The NAPLEX will only round to throw you off, so round to the 10th, round to the 100th, but they won't keep numbers very close. So they won't make you try an answer that's 10, and if you play around with the numbers and round it, you might get 11 or 12 accidentally. 11 or 12 won't be there. It'll be 10, 15, 20. They'll space them out. So if you're rounding these numbers to remember these conversions, you're more likely not going to have something very close, and then you want to avoid rounding. You'd be pretty safe to round throughout the entire exam. So volume conversions, you want to know for sure. Weight as well too. Um, One thing to notice though is when you go from tablespoon to ounce to cup to pint, you have your ounces there of 8 ounce to 16 ounces for a cup to pint. But when you go further to quart and gallon, you have 2 pints and 4 quarts as well too. But notice the common theme through all of this. It's milliliters. Milliliters is key. You will more likely see a conversion from milliliters to pints or a milliliters to quarts than you're going to see a pints to gallons or a quarts to cup. So the big takeaway point for you guys here is to make sure you know that milliliter conversion. If you did a milliliter conversion, more often than not, you can work your way through the rest of this and get to the answer you want. Again, weight conversions needed, height conversions needed as well too. Milliequivalents, millimoles, just like your NAPLEX book will say for y'all, that's needed as well. So ratios. Ratios is used by the NAPLEX to describe the proportion of ingredients in a medication itself. So if you have a 4-to-1 ratio, what that's telling you is in whatever compound you have, the 4-to-1 means you have 4 parts of substance A and 1 part of substance B. It's pretty straightforward. You can even play around with that and flip it over. Instead of 4-to-1, you can say 4/1 as a fraction as well. This manipulation is going to be pretty important as we go further down and work on other problems as you get into the NAPLEX as well too. When you might be provided a ratio, but to solve the problem, you'll need to use a fraction instead. Or you might have a fraction, and to solve the problem, you need to flip to a ratio format to get your answer instead. So that's going to be key, is knowing these quick conversions. So what's important with ratios, you want to know that, yes, it is a 4-to-1 mixture of 4 parts of one ingredient, 1 part to another. But more importantly, you also want to know that 4-to-1 can be converted to a fraction of 4-to-1 itself. And then you'll start using this ratios to actually use in proportions to calculate the actual quantity of what the ratio might have. So yeah, it's great. It's 4-to-1. But what's the quantity? How many parts do you need for one, and how many parts do you need for another? You'll see this a lot in allegations as well, which we'll start in a little bit. Body weight calculations. For the essence of time, I feel like I'm gonna breeze through this, but you do want to know ideal body weight, adjusted body weight, actual body weight. You guys have been doing this since P1 year, so I'm pretty confident you guys will be able to tackle this, and we won't need to spend a lot of time on this. But definitely want to know your body weight conversion. If you don't, please take the time out to know these. They'll be very important, especially for calculating dose adjustments, renal adjustments. This will be key. So again, renal adjustments, kind of what we're talking about with the weight, and see how it's ideal to know your ideal body weight, your adjusted body weight, and your actual body weight, is because you'll need it to choose which weight to use for this equation. It's great to know what your creatinine clearance equation is, 140 minus age times weight over serum creatinine times 72 times 0.85 if you're a female. That's great to know. Most folks will know it on the top of their head. But some people tend to forget what weight to use, and that's going to be specific in term and how much your creatinine clearance can be thrown off if your weight's off as well. So, just key concepts to know here If your ideal body weight is greater than your actual body weight, you're going to use your actual body weight. If your ideal body weight's around relatively the same as an actual body weight, we want you to use ideal body weight. If your actual body weight is greater than your ideal body weight, so you're more obese patients, that's when we need to start considering to adjust based on that obesity. If your BMI is less than 25, you want to use ideal body weight. Again, you need to know BMI as well. If your BMI is greater than equal to 25, we want to use adjusted body weight. And that's going to play a role here and what you plug into the weight to calculate creatinine clearance. Off topic, but related to renal function, not creatinine clearance, but if your BUN to serum creatinine ratio is greater than 20 to 1, again, you want to be able to build this based on knowing how to do ratios. Anything over 20 to 1 means that patient's going to be dehydrated. That's going to be more of a word question where they'll ask you, is this patient dehydrated? And you'll need to be able to go back in and check that patient case they give you and see what is their BUN, what is their serum creatinine. When we smack them together, what's that ratio? Now, is that ratio greater than 20 to 1? Okay, yes, he's dehydrated. If it's not, okay, he's not. That's easy points that you can easily get that you don't want to screw up and throw away because those points add up at the end. Absolute neutrophil count, another easy one. Big thing you want to know is you want to, but not actual calculations itself, but knowing this table. You want to know what normal is, what neutropenia is, what severe neutropenia is, what profound neutropenia is. But you'll get this in a calculations questions all in one. And knowing the equation as well too, that's pretty straightforward to know. Arterial blood gas. So we're going to start diving into the more complex questions. And this is where I'm going to start asking questions to you guys as well. And I'll be calling out some names to give me some answers. So pretty straightforward concept if you think about it. Your body has two major systems to regulate the pH of your blood. And our pH needs to be between 7.35 to 7.45. It's a very narrow range of 0.1. So how does our body adjust accordingly if that pH gets skewed? Well, we have two ways. One is through our kidneys. Our kidneys release bicarbonate to balance out blood if our blood starts becoming more acidic. And remember, acidic means down. So if our pH level starts dropping, kidneys will kick in, create more bicarbonate, and release it into the bloodstream and balance that out. Your lungs, through your breathing, does the opposite. It decreases your pH when you're carbonic acid with carbonic acid, your PCO2, when your blood starts becoming more basic. So when that pH starts going up, you start breathing more, and that CO2 starts bringing that acidity to the blood, dropping that basic blood depth down to a more normal range. Essentially, what you're going to get within the NAPLEX is you're going to get a patient case. You're going to have a patient reporting to ER. They'll give you an ABG formulated exactly like this. So this is how the setup you're going to see your ABG. So you'll want to know this setup because they won't tell you pH equals A, PCO2 equals B, PO2 equals C. They're just going to give you this almost like small fishbone in a way. And you'll need to be able to realize, okay, my pH is first, my PCO2 is second, my PO2 is 3, my bicarbonate score. And based on these numbers, you'll need to assess what the patient status is. So again, reference ranges are important as well. You might get lucky and they might provide you that as well. You're playing with fire, but there's a good possibility that might be provided for you on the NAPLEX. But again, it can be hit or miss. That being said, how do we interpret our ABG? So when you get an arterial blood gas, you want to do a couple things. First off, you want to determine if they're acidotic or alkalosis for this patient. So again, remember, our range is 7.35 to 7.45. Anything less than 7.35, you're acidotic. Anything more, alkalosis. Pretty straightforward concept. That's going to set the foundation for what you do next. So low pH, acidosis, high pH, alkalosis. Now we want to look for the abnormal values to figure out which one is right. So if your CO2 level, 35 to 45, is low, that means it's respiratory in origin and has alkalosis. If your PCO2 is high, over 45, you're acidotic. But that's not the final answer, though. We also have to consider metabolic. Bicarbonate being high right? So your bicarbonate being over 26, your alkalosis. Low, under 22, means acidosis. Now you have two different components. You have your pH, and now you have either a low CO2 or high CO2, or a high bicarb or a low bicarb. You want to match these two together to get your relative answer. So if you have low pH and high CO2, you're most likely going to be respiratory acidosis. But you also want to consider one last thing. So at 3, you want to match abnormal value, whichever value is abnormal for your carbon dioxide or your bicarb, to 1. So if it's acidosis or alkalosis. But what if both CO2 and HCO2 are abnormal? What does that mean? Do you want to answer that for me in the chat? Or you can turn on your speaker and answer that? Yeah, awesome, Caitlin. Thank you so much. Compensation. So yes and no. So essentially, you're right. Your body is going to compensate based on what level is abnormal. So when you have a CO2, your carbon dioxide, or your bicarb is abnormal, usually the opposite will go the other way. And that's what you call compensation. And we'll see that in the next question we have in a second to try. But your body's going to compensate. So if one if your CO2 is going one way, either high or low, and on the flip side, your bicarb is going the other way, that's your body's way of telling you, okay, yes, your body's recognizing that your respiratory acidosis. Your body's kidneys are trying to compensate now by going the other way. So that's something to keep in mind as well too, because that can very easily throw you off. One thing to keep in mind as well too is whenever you have a level that's closer to your norm. So let's say, for example, you have a PCO2 level of 58, but your HCO3 level is 20. You're going to lean more towards that highly abnormal level versus your HCO3 or bicarb being closer to 20 to 22, because that's your body slowly starting to adjust. The wildly outlier number is what you want to focus on during the NAPLEX. They're not going to try to trick you that way. So that being said, I'm going to do y'all's first question for you guys. John Wick reports to the ED with shortness of breath and a productive cough with some yellow-green sputum. His ABG came up as a pH of 7.3, a PCO2 of 68, and HCO3 of 28. What does he have? I'll give you guys a minute to kind of think this through, look it up, compare to your ranges, and let me know what you guys think. Or does anyone have any answers for me? I got a respiratory acidosis. Anybody agree with Anita? Thank you, Anita, for that. not breathing well, maybe hyperventilating, increased CO2 content, respiratory acidosis, bicarb increases to compensate. I like the thought process, Jason. I really do. Um, I like, let's see, respiratory acidosis with metabolic compensation. All right, so I see I have 3 respiratory acidosis. That's great. Thank you guys for that. So let's work it through. So what do we have? So our pH is low, so acidosis, you guys got that right, right? 7.3, 7.35 is our lower end, so you're right. We're low there, so we're acidotic. Our PCO2 is high, so that's respirant origin, so acidosis right there, right? Our PCO2 is 68. Our range is 35 to 45, so we're high there. So that's acidosis based on what we're taught here, right? Respirant origin, high CO2 is acidosis. Our bicarb is high as well too. So what about metabolic alkalosis? But Jason makes a very good point. And so does Caitlin. We have to think about compensation. So even though both are high, remember 28, 26, we're not far off. That's really not that far off of a difference. So our body is starting to compensate and starting to kind of make that bicarb increase as well too. So our PCO2 matches our pH, right? So acidosis for our bicarb, I'm sorry, for our carbon dioxide. So since those two match, we're good to go. We are respiratory acidosis with some partial compensation metabolically. So you guys nailed it. Good job. So that's the only in-depth one we'll be doing for basics. Compounding is where it really gets to be the nitty gritty and the meat of what we're going to learn for the NAPLEX. So the NAPLEX will hit you guys as well too. So some quick run throughs. Percent strength. This is something that you guys have done all throughout pharmacy school when you guys do calculations, when you do labs. And the big things you want to walk away with is when you're doing a percent of anything, percent weight, percent volume, percent weight and weight, your liquids are out of mLs, milliliters, but your weight is out of grams. That always threw me off. I always either got, either I would do milliliters and milligrams, or I would do grams and liters. Please, please, please remember this. If you walk away from this entire presentation, I want you to know this. Your weight is grams, your liquid is out of milliliters. That's going to make life so much easier for you guys. Just a brief run through with it. Your percent strength gives your percentage to represent the number of parts of an ingredient out of 100, just to kind of understand the concept behind it. Some of the common fluids you'll need to know. Now, this you will need to know. You want to know your normal saline is 0.9%. So what does that mean? Your normal saline means you have 0.9 grams of NaCl out of every 100 mLs. You want to know, take that concept and you want to know 1/2 normal saline, 1/4 normal saline. If you know what normal saline is, 0.9 grams per 100 mLs, you can figure out what 1/2 normal saline is. So what's 1/2 of 0.9? 0.45. What's 1/4 of that, etc. You also want to know your D5W as well too. So D5W dextrose, right? So that's 5 grams of dextrose and 100 mLs of liquid as well. So just some basic common IV fluids. You'll need to know this because they'll give it to you and they'll assume you know what that conversion is because you'll need to use that conversion to solve the problem. So I definitely want to keep these in mind when you guys go into the NAPLEX. Ratio strength, forget everything you know about ratio strength. Just know this one shortcut. If you know this shortcut, you're good to go. Ratio strength to percent strength, you're going to take percent strength and do 100 over ratio. So if they give you the ratio strength, you're trying to find the percent, you're just going to do 100 over the given ratio, solve, that's your percent strength. If they give you your percent strength and they're like, give me ratio strength, you're just going to take 100 over the percent strength, and that's going to get your ratio strength. So whatever they give you, and they're asking for something else in terms of the strength of the compound, strength of the drug, you're just going to take 100 over whatever they give you, and that's going to give you the opposite. It's a really, really simple concept, but it can really come handy during the NAPLEX. So definitely know this shortcut and know it's for percent strength and ratio strength to switch from one to the other and make your life a lot easier during the NAPLEX. Parts per million, another shortcut. Forget everything else. Just know if you have percent strength, how to get parts per million. Now take a step back before we even dive into all of this. What did we just learn? We can convert a ratio strength into a percent strength. Now I'm saying you can turn a percent strength into parts per million. The NAPLEX will probably take ratio strength and tell you to do parts per million. So you need to know that step in between. To take a ratio strength to get a parts per million, I got to have that percent strength in the middle as well too. But hey, you guys know how to do it because you guys know how to convert ratio to percent strength. And now you're going to take percent strength to parts per million. So if you're taking percent strength to parts per million, you're going to take that percent and you're going to move that decimal. So instead of, say if you have 10%, you're going to convert that to a decimal form. So 10% is actually 0.1. You're going to take that decimal in front of the 1 and move it right 4 places. So moving it right 4 places means 10% is actually 1,000 parts per million. And the opposite, if you have parts per million, say if you have 0.1 parts per million, you're going to take a decimal and move it left. So 0.1 parts per million is actually 0.00001. I think I have the right zeros in there. If I don't, apologies. But that's the concept behind it. You want to just know these basic concepts because it's going to allow you to manipulate these questions very quickly during the NAPLEX. As you start doing more of NAPLEX prep, you'll realize you might know the concepts, but time is your worst enemy. You're really fighting the clock, and you want to be mindful of that time. So stuff like this that can save you 30 seconds, 60 seconds, the 60 seconds more you can use towards a complex disease state question because you knew how to breeze through it with a shortcut. So these 2 shortcuts, please, please, please know. If you don't know anything else about parts per million, percent strength, and ratio strength, just knowing the shortcuts will sometimes just be enough for you to work your way through a problem. Moles and millimoles, this is something that you guys did with Gen Chem, Orgo, so I'm not going to harp too much into it. Moles is the molecular weight of a substance per gram. You guys know how to manipulate that. Millimoles is 1/1000th of a mole. So we'll use that later on, but just know what it is. If you need a refresh on your Gen Chem or your Orgo, please do, because this will be something that you'll see in the NAPLEX as well too. So in-depth concepts. So specific gravity. So specific gravity, to know the concept behind it, it's a ratio of the density of a substance. So my cup, the density of this cup over the density of water that equals the volume of this cup. So let's say, for example, this cup is the volume of this cup is 5 mLs. What essentially I'm saying is the density of 5 mLs of this cup, I'm going to take that and place it over the density of water at 5 mLs. So the volume is going to equal the same. It's the density difference that we're really worried about, and that's what's going to make specific gravity. So just like our example, so one key concept with this is water has specific gravity of 1. Why? It's a little bit of critical thinking. Why does water have a specific gravity of 1? If you know nothing else and just know what I told you about what specific gravity means, why is water equal 1? So this one's a little bit more tricky, and it's not technically calculation, so I'm not gonna make y'all sweat over this. But essentially, if you think about it, specific gravity is the density of a substance over the density of the same volume of water. So if the denominator is always water, we need to have a denominator for something if the specific gravity of what we're looking for is water. So it's just x over x equals 1. So whatever the denominator is, that's our numerator. The concept behind that is this. If we know specific gravity of water is 1, because your bottom, your denominator is always weight of volume, equal volume. Let's say we're given a prescription and we're told, find the weight out of all these items. and they give you specific gravity to solve it. And one of those items is water. Boom, you know the weight of that. Because if they, for specific gravity, if they give you a volume, you don't need anything else. Just the volume is the grams. So if I have 25 grams of water, sorry, I'm so sorry about that. If I have 100 mLs of water, how many grams of water do I have? Now that I'm going to wait for someone to respond to me for that one. If I have 100 mLs of water, knowing specific gravity, how many grams of water do I have? Thank you, Caitlin. 100, exactly. So that will make your life so much easier, and you will see it in a practice problem itself further on, where if you know water being a volume, that equals grams as well too, that will come up in calculations. Everyone I spoke to from my class had that concept in their specific gravity question. So specific gravity, the equation is weight of a substance in grams over weight of the equivalent volume of water. But more easily, you want to know specific gravity is grams over ml. So here's a question for you. Remember, specific gravity is grams over ml. Calculate the volume in mLs of 1 kilogram of sulfuric acid with a specific gravity of 1.83. Again, specific gravity is grams over ml. So I've given you the kilograms, the weight of it. What's the volume? I'll give you guys about 2 minutes to solve that. You guys can just go ahead and post it in the chat for me. I got one. Anita got 546. Thank you, Anita. Caitlin 546 as well. Anyone else feel different? Anyone else get 546? I used to be the one in class whenever someone would post an answer, I'd like wait for 2, 3 folks to post their answers. I'd be like, oh, that's got to be the right answer. And I'll enter it myself right behind it. So that used to be me in class. So no shame if y'all want to answer that as well too. After that, I was the exact same person. All right. Well, I want to be mindful of y'all's time. I know we told y'all 2 hours and we're approaching it. I might go a little over, but I don't want to get too much over. So 546 is the answer. So yeah, pretty straightforward. This is one of the more simpler questions on the NAPLEX. So if you had difficulty doing this within a timely fashion, like 1 to 2 minutes, please, please, please take some more time with your calculations in general, because this is a very straightforward question. You just take an equation, you're plugging and chugging. Plugging and chugging is the most basic way NAPLEX will ask you a question. There's no manipulation. You're just plugging a number and you're solving the equation. The NAPLEX is going to make you manipulate these equations, kind of like that whole, if you have ratio strength to get parts per million, you need to manipulate 2 equations to get it to work. This is very simple plug and chug. So if you struggled with this, please either reach out to me. You have my email. I'll be more than happy to help you guys, or spend some more time with calculations, because this is going to be a simple plug and chug question. You know your equation for specific gravity. Specific gravity is grams per ml. You have your kilograms. You just convert it to grams. So 1 kilogram equals 1,000 grams. Again, remember the very first thing we talked about was those conversions. It's very key because of stuff like this. So you have 1,000 grams over an X amount of mLs, and you know specific gravity. So you just manipulate it, move your, you just multiply your X mLs over. So you have X mLs times 1.8 equals 1,000. Divide your 1.8 over. So 1,000 over 1.8 equals X mLs, which that equals 546. So thank you, ladies, for that. This one's a little bit more complex. So we went from a basic, easy question to something a little bit more NAPLEX style, if that's a thing. Question is, you receive an RX to prepare the following compound. You have steroid H, which is 600 milligrams. You have isopropyl alcohol with 4.3 ml. Specific gravity of that is 0.78, and purified water at 25.7. When you make this compound, what is your total weight in grams of the compound you're making? Round to the nearest whole number. Give you guys 3 minutes to do this. At 7:25, I'd like to get some answers from y'all. All right, so it's been about 3 minutes, a little over. I don't have any answers, so I guess my question to you guys is then, what about this question was the holdup? Where did we have a little bit of difficulty manipulating this question? Because that's going to be the most important thing, is how do I manipulate this question to get the answer? So can someone let me know what made this question a little bit more difficult to solve? We're getting total weight. So we need to take all three of these and find out what the total weight of this when you have two liquids and one weight. So what about this question was hard, or what was easy? What was easy about this question that we were able to solve? Anyone? Okay, well, to solve this question, right, we need to have three different weights. Remember, with water, what do we know? 30 grams? Uh, let's see. You're right, Anita, it is 30 grams. So what do we need to look at here? We have one weight, right? We have our steroid. Weight's given to us. Remember the concept I talked to y'all about specific gravity in water. Whatever weight you have is going to equal the liquid quantity. So specific gravity is grams per ml. Water equals 1. So whatever ml is, that's your weight. So technically you have two. You have 600 milligrams of your steroid. You have 25.7 grams of your water. All that's left to calculate using this question, same format that we did before, is the isopropyl alcohol. You need to take your specific gravity, 0.78, and use this 4.3 mLs to get your grams. So how are we doing this? Again, what do we know? We have the weight for the steroid, 1 down, 2 more to go. We know with water, specific gravity of 1. So if you're at 25.7 mLs, you have 25.7 grams. So what's left? Isopropyl alcohol. You're given the specific gravity of 0.78 and a volume. So if you set up the equation, you just plug and chug now. You plug in 0.78 for specific gravity. You're solving for x, which is your grams, over 4.3 mLs. And you work it out, and you find out x equals 3.34354 grams. And you just add them all together. Key thing to remember, though, is don't forget your steroid is in milligrams. You want everything in grams. So when you add it all together, you get 29.65 grams, which Anita nailed and said 30 grams. That's the answer. So good job, Anita. Dilution concentrations, I want to be mindful of your time. We're hitting 7:30, and I don't want to spend too much more longer for you guys, because I know you guys have work y'all have to do. So we'll breeze this real quickly. But you definitely want to know Q1 times C1 equals Q2 times C2. Key thing to know is the units on each side must match. So if you have grams on one side, you need to have grams on the other, milligrams the other side, milliliters, et cetera, et cetera. Draw out the equation first. Draw almost like a plus sign, and then put your numbers on each side. So if the left is a gram, make sure your right's a gram. If the bottom is a milliliter, you want the bottom on the other side to be milliliters as well too. So Q1, so quantity 1 times concentration 1 of what you're looking for, what you have, should equal quantity 2 of what you're looking for, or concentration 2 of what you're looking for as well. Pretty straightforward concept. I'm going to skip these questions just for the essence of time. I've entered the actual thought process itself, but again, not much of a detailed answer because it's a pretty straightforward concept. This one I do want to spend time with because this is a little difficult. Allegations. So your dilutions and concentrations deal with two concentrations. So if you see two concentrations, either they provide two or they give you one and they're looking for a second, that's two concentrations. You're most likely doing dilution or concentration. A Q1C1 over equals Q2C2. But if they give you three concentrations, so either they provide three concentrations or they provide you two and they're looking for a third, you're going to do an allegation every single time. Sometimes the question alone will tell you what procedure you want to use for this exam. Allegation is one of them. So key thing you want to know here is how to set it up. Just draw an X. You want to know your top is your highest percent on one arm, the bottom arm is your lower percent. The middle is what your desired percentage is, what you're trying to get from combining two of those concentrations. And then you're going to solve it with your parts on the other end. So essentially what you're saying is you're having two concentrations of a drug, ointment, etc. What happens when I combine them to get a certain percentage, a certain concentration? So if I have concentration of 5% and I want to make 2%, what do I add to the 5% to get 2%? That's one way to use this equation. Or if you have a 5% and a 2%, what concentration I get when I combine the two together? So you can find two different sets of answers. You can find a final concentration or you can find a starting concentration using this method. And that's the bottom, essentially what it is right there. What you do is what you take your setup, you have your higher and your lower and your desired, and you work your way across. So notice the top right, you don't go across, you follow the arrows. So your lower percent minus your desired percent equals the parts. Now, it doesn't have to be in that order. If you have a 1 here and a 0.5 here, you don't have a negative 0.5 parts. You just have 1 minus 0.5 equals 0.5 parts. Work your way across as well, too. Higher percent minus the desired percent. That's how many parts you have. And then you add your parts straight down. So if you have a 0.5 here and you have a 3 here, you add them together and you have 3.5 parts of the two parts. That being said, does that make sense? Do y'all get that? Please say yes or no to me on this one, because this is gonna be this is a difficult concept, and this is something that you will have on the NAPLEX. I guarantee it will be on the NAPLEX. Any questions to it? No? Yes? Maybe? I want this seminar to be over. No? All right, cool. Well, we go forward. Question 1. Pharmacist is asked to make a 0.5% ointment of Bactroban. How many grams of PEG ointment base must be mixed with the contents of a 2% Bactroban tube? So read the question carefully. You have a 2% tube of Bactroban, 22 grams, and anyone that works in retail knows that that's how it comes. As your mupirocin comes in a 22-gram tube, most likely. How much PEG do you add to that whole tube to get 0.5% ointment of Bactroban? You know what? I'll be nice to y'all. To be mindful of time, I'm just going to go and show y'all the mechanism of how to work it out. So what do we have? Let's talk this through. You have a 2% tube of Bactroban. So what percent of PEG ointment do I put in? I'll let y'all answer this one. So I'm showing y'all how to work it out. What is the percent of my PEG ointment? Bactroban's 2%. I'm trying to get 0.5. What's my percent of the PEG ointment? I'm plugging into this equation. Yes, Madeline, Brian, thank you. 0%. PEG is nothing. It's a base. It's a mixing agent. It's a emulsifying agent. It's an agent that we're using to dilute the Bactroban. There's no percent of any drug in there. It's just a mixing agent. So you're right. We're going to use our higher number, which is 2%. It's going to go on top. Our lower number, which is our PEG, is the 0. It's going to go on bottom. So 2% of the Bactroban minus 0.5, that's the Bactroban we want to get, that's 1.5 parts. 0% of your PEG minus 0.5 equals 0.5. That's 0.5 parts plus 1.5 parts. That equals 2 is our total sum of the both ingredients. So essentially what we're saying now is whatever our final total amount is, we're going to have to break it by 2 parts. So we know that our Bactroban, that was our higher number, 2%, we'll need 0.5 parts of that Bactroban. Well, the good thing is we know the quantity. We're using this whole tube of 22 grams. So 0.5 parts equals 22 grams. We know that. So if 0.5 parts means 22 grams, that means 1.5 parts using that concept gets me 66. So for every 0.5, 22. 0.5, that's 3 different parts. 3 times 22, 66. So that's how much PEG ointment we'll be using to make the 0.5% ointment. I'm going to go through these concepts. The questions will be in here for you guys to solve. I'll let you guys review them yourselves. You guys can reach out to me with questions instead. I just want to make sure I get through this in a timely manner for y'all. Osmolarity is going to be another difficult concept to know as well too. Essentially what that's looking at is you're looking at the osmotic pressure that is in relation to the total number of particles in the solution. I know it's a bunch of gibberish. So what does that mean? That means that you have a solution. Say in my cup, I have a set amount of particles in there of whatever I have, air, water, liquid, whatever. There's a number, a total number of particles in here. Let's say that number is 100. How much pressure, osmotic pressure, that 100 particles has is my osmolarity. So how do we measure that? Total number of particles per liter of solution, or osmol per liter, but you'll most likely see on the NAPLEX as milliosmoles per liter. And what's the key here? You want to know that whatever you calculate, you got to balance it out by 1 liter, which is your 1,000 right here. You want to balance that out. Why do we do that? Because we got to get consistency across the board. We want to know how many particles we have out of 1 whole liter. And we want to balance that out for consistency to compare one to the other. The equation is this right here. Milliosmoles over liter equals weight of a substance in grams per liter. Like now, key point, key difference. What is our percent weight over volume? That's a off-topic question. We talked about it. What is percent weight over volume, or percent W over V? What are the equations do I use for that? What weights and what liters, or what milliliters, or there we go, grams per 100 liters. Thank you, Caitlin. So percent weight over volume is grams over 100 liters, but here we want the weight of a substance in grams per liter. So don't let that throw you guys off. That's going to be an easy way to lose points. A lot of my classmates I spoke to lost points here because they did grams per 100 mLs. We want grams per liters over molecular weight of grams over mole times the number of particles times 1,000. So what is the number of particles? You want to look at the compound in question and know this table. This is going to be key. You will need to know this table. You'll need to know dextrose doesn't dissociate to 2 particles. It just stays as 1. So does mannitol. This is in your NAPLEX book for your RX prep. HCl dissociates to 2, NaCl equals 2, etc., etc. What you want to know is these 3 steps. Determine the particles using this table. You want to know the amount of the compound in grams found in 1 liter. So if you're looking at NaCl, you want to know the amount of that in grams found in 1 liter and then solve using molecular weight. So that being said, if you have a solution with 373 milligrams of sodium ions, actually, I'm sorry, I said we're going to skip all that. So that's a concept you want to know how to solve it. So actually, I'm going to solve it real quick for you guys. You have a solution with 373 milligrams of sodium ions per 1 liter. How many milliosmoles of the solution is in the solution if the molecular weight is 23? So pretty straightforward. You know that you want to get grams per liter, right? So you have milligrams per liter. So we convert that to grams per liter, right? So just know your equation for conversions. 1 gram is 1,000 milligrams, gets you 0.373 grams per 1 liter. Now you just plug and chug. You were given the equation, weight of a substance, you have that now, 0.373 grams per liter. You were given the molecular weight, 23. That's 2 right there. Number of particles, what do you have? Sodium. Sodium is 1, right, based on our table? Because NaCl is 2. Just sodium is 1 particle. So you have your particles, and you times 100. So all you do is plug and chug now. So this is just a simple knowing the equation, knowing the basics of manipulating grams and milligrams, and easy points right here. Very easy points. And you get 16.2 milliosmoles. Isotonicity is something a little bit different from milliosmoles. Here you're looking at not just the osmotic pressure of one substance, but the pressure between 2 substances. And why is that important? We don't want to put a substance that's a different tonicity into your body. Your body is isotonic. The fluid in your body is isotonic. Your body lives thanks to the balance that it has, and it's a fine balance. If you inject a drug into your body or into someone else's body as a patient, you don't want to throw off that perfect balance we have. So you want to make sure the drugs we develop, if you're in an IV room, etc., has isotonicity. That's why this is important. To calculate it, you'll need a couple key things. One of them is a dissociation factor, which is going to be your I. Know this table. You want to know that the factors based on the number of ions, you want to know this factor right here. So if you have 2 dissociated ions, so like 2, for example, you want to know your factor, I value isn't 2, but it's 1.8. If you have 3 dissociated ions, your factor isn't 3, but it's 2.6. This table is key. This is also in your RX prep book as well. Next, you want to find your E value. E value essentially is your sodium chloride equivalent. So if your body's equivalent, your body's isotonic, it's got that perfect hormonal balance. Your equivalent pressure is of NaCl. That's why we always put everything in NaCl. We inject yourself with NaCl if we're just testing how to inject and learn, injection skills. You use NaCl. Why? Because it's isotonic. So if your bodily fluid is isotonic and NaCl, sodium chloride is or normal saline is isotonic, that's our pressure equivalent. We want to shoot for that. So our E value is based on that. So 58.5 over the I, molecular weight of the drug over 1.8. You'll need to know this equation as well to plug and chug. Based on that, you have your E value. Now what? If you have your E value, remember, your first step is your isotonicity, your I value. Once you get that, you can get your E value. Once you get your E value, it's pretty straightforward. Your E value lets you find out how much sodium chloride you'll need for any drug you're developing. Because remember, sodium chloride helps tonicity. You have a positive ion and a negative ion. That's great to create a buffer for you to balance things out. So you want to figure out how much sodium chloride you need to add into whatever you're building. So you take the desired volume of your total compound and you multiply it by 0.9 normal saline. That tells me out of this volume, I need to have this much sodium chloride. Now I know what my total sodium chloride needs to be because I know based on how much I'm making. But how much sodium chloride is coming out of the ingredients I'm using to make whatever compound I'm making? I know my total volume. I know how much sodium chloride I need to have for this total volume, but I'm mixing stuff into it. And if I'm mixing stuff into it, I might have residual sodium chloride in what I'm using to make this compound. So I got to account for that as well too. So find out how much sodium chloride the drug has. That's where E value comes into play. So your E value times your total drug amount. That tells you how much sodium chloride is in the drug in question that you're mixing into your total volume. So now you have your total volume, how much sodium you want, and you have the sodium that's coming with the drug you're mixing into it. So if you have a total of what you want, and you have an amount you're adding in, you minus the two. And that's how much of how much sodium chloride you need to add into your final product to make it isotonic. Hopefully that explanation made sense. I try to make it as simple as possible. Probably didn't sound simple, and I apologize. If you have more questions, please email me about that. Practice problem, I'll leave that to you guys. Last concept, and we'll be done, is our nutrition calculations. You want to know your two types of nutrition, so your parental nutrition and your enteral nutrition. More specifically, you're going to see PN on the NAPLEX. So you'll want to know the two types. 2 and 1 is just dextrose and amino acid PN. 3 and 1 is dextrose, amino acid, and lipids. You'll need to know this for calculations because you'll need to know how much caloric benefit you're getting out of dextrose, amino acid, and lipids. And if you know what type of PN it is, let's say, for example, they tell you how much caloric benefit do you get from a 2 and 1, and they give you all three values. You have your KCl gain from dextrose, KCl of amino acids, and KCl of lipids. If you don't know what 2 and 1 means, you won't know which of those three to use from those three values. So you'll need to know this for the NAPLEX. Types of nutrients and their values, you'll want to know this backwards and forwards, and not just the energy provided for your carbs, fats, and proteins, but these formulas as well too. These formulas will pop up, and you'll need to know that even though fats give you 9 kcal per gram, ILE or injectable lipid emulsions 30% only gives you 3. That's a third of what natural fat's going to give you. So you'll want to know both of these backwards and forwards. Also, you'll also want to know grams of nitrogen per protein. Easy points. This will almost definitely show up for you guys on the test. And these are easy points to be had. Must know formulas. These are formulas that RX Prep tell you to know, but I'm going to re-emphasize that. We didn't go over it in details, but you'll want to know your corrected calcium for if your albumin is less than 3.5. You'll want to know your flow drop rate calculator to calculate your drops per minute based on whatever they give you. Most likely they'll give you drops per ml. and you'll need to know how many drops per minute that the patient will need. You'll need an anion gap, pretty simple, sodium minus chloride minus bicarb. You'll need the milli equivalents as well too. That's a little complex. So if you need me to, ever sit down and talk to you guys with it, I'll be more than glad to. And you'll want to know your TEE, your total energy expenditure from your basal energy expenditure times activity factor times stress factor. Caveat, they will give you activity factor and stress factor. I'd be very shocked if they don't. They will give you that 1.2, 1.3 that you're calculating into that based on whatever distress your patient has. So most likely in what case you will see is you'll have a patient in the hospital, you're working with a nutritionist, you're trying to figure out how much of their caloric need they need. They'll tell you patients burned. If they're burned, this is their stress factor of 1.2 or 1.3. Or patient is non-ambulatory. This is their activity factor based on that. They'll give you that. You just need to know BE times activity factor times stress factor gives you your total energy expenditure, which is how much your body's going to burn in terms of calories. That being said, that ends it. I apologize for having to rush to the end. We didn't want to keep you all past the 2 hours. Does anyone have any questions now? Or if not, you have our emails. Feel free to email us and contact us. We'd be more than happy to help y'all. But I do want to open up to questions now if y'all have to. If not, your guys are definitely free to go. Thank you so much for taking time to sit down with us. Hopefully this was helpful. This is recorded, so you guys can go through, and we will provide these slides as well too for your benefit as well. Disclaimer: a lot of this stuff did come from RX Prep in terms of basic concepts. A lot of my questions came from what I was taught through my fourth year training. We were given a lot of pack fits, etc. from my school. I think Victor's came from RX Prep as well. So this stuff will be in RX Prep as well. We just try to consolidate it to make it easier for you guys to review. That being said, thank you guys so much. We will stick around for questions. If not, y'all have a great night.
Okay, I'm gonna stop recording this and see if I can compress this. This would probably not a good idea doing this on a VA desktop. But yeah, everybody, thank you for coming. We'll be sending out the email shortly. So yeah, last call. If you haven't put your email address, if you came in a little bit late, please do so. We'll be basing off whoever put it in. They'll be part of our mailing list for the slides and the recorded lectures. Thank you.